Good evening and welcome to Open Line. We are talking about lung cancer. Again, if you have any questions, please call the number on your screen, 615-737+. Dr. Grogan, I want to ask you, as far as a viable candidate for surgery,
sure.
What do you kind of check off the list?
Sure. So in order to be a candidate for lung surgery, one has to have enough lung function once we finish taking out the lung cancer to be able to obviously survive and then have a good quality of life. And so we actually do very careful measurements before we do a lung operation in order to determine whether they have enough lung function. And a lot of that's determined by how much underlying emphysema that they have from their smoking, and also their sort of total overall strength. And we get pulmonary function testing, and maybe Kathy could talk about sort of what she went through here in a little bit. But one of the things that we do is we measure the total lung function, and then I will then measure how much lung that I think we'll need to take out and how much percentage that is, and then come back and say, is this patient then going to have enough lung function remaining to be able to have a good quality of life and do the right cancer operation.
And what did they find for you?
They did the lung function test, and I had enough lung function that when they removed the upper lobe, I should be able to function normally.
Do we know how much was taken?
Sure.
The entire lobe?
That's correct.
Upper lobe?
So if somebody has an early stage lung cancer, currently the standard of care is to take the lobe or the section, the lobe of the lung, to go with it, as well as the lymph nodes and the drainage. And so for her, she had adequate amount of lung function so that we could do a lobectomy, which is the standard of care. In patients who have maybe more emphysema than she had, then we can take less lung if we need to. But the standard, if you can tolerate it, is to do a lobectomy.
So that's obviously she needed surgery, but then there are those who may not need surgery. What are the other options?
Sure. So if somebody is a candidate for surgery, then obviously surgery is the standard of care, and that's what we do first. If they don't have enough lung function, there are other treatment options, which is good. In the current sort of standard for somebody who has an early stage lung cancer, like we had here, who could not tolerate surgery, would be what's called stereotactic radiation, which is a focused beam radiation. Now, I don't do that therapy, but we certainly refer people for that therapy who need it. And it's a focused beam radiation where it just focuses the radiation beams right in that area and really just kills that area around the tumor itself. And that can be very efficacious for people, and I've actually recommended that for friends and family who could not tolerate surgery.
You also mentioned before palliative care. About that.
So palliative care is essential also at all aspects of chronic diseases, and cancer is a chronic disease, right? When people come to a point where they don't really expect a cure anymore, their goals change. And when the goals change, they typically go into a mode where the quality of life is the priority rather than the quantity. And the quality of life means different things to different people. It means different things to Kathy, to you, and to anybody. But there are specialized teams now at Vanderbilt in many different hospitals who are experts at addressing the goals of care once the disease is not curable anymore. And that implies a variety of interventions that you can think about. We can think about pain control for sure as being essential, and we should be good at providing pain control, and it's a difficult goal to get. We think about quality of life in terms of your ability of doing your activities of daily living, for example, the amount of help you need at home, the tools we can provide you with, and other more holistic approaches to understand what your goals are, what your spiritual needs are, and basically help people live and try to control the disease as well, knowing that there is not a direct cure. But when the goals have changed, the mentality is changed, and there are expert teams to really help us. So we commonly refer people like this to these expert palliative care medicine experts who then take care of these people until the end.
Kathy, for you, any goals that you had to change? Anything as far as lifestyle changes after the surgery? What were some of them? Pretty much saying, how is life after surgery? Because I know it's not always the best outcome. There's also some of the symptoms you're still facing.
What I deal with on a daily basis now, obviously, is shortness of breath. That is probably my largest problem. It doesn't affect my daily life very much. I still work. I still see clients. I can't do things like I will never be dancing again. I have difficulty spending a lot of time walking, taking my grandchildren for walks. That's difficult. So I have to change. I have to change up what I'm doing.
All right, Kathy, thank you. We have now Joe. Joe, good evening. What is your question?
Yes, I've been diagnosed with stage 4 lung cancer in both lungs. And I've gone through chemotherapy for 2 different types. And I go back the end of this month for CT scans. But is there any further treatment that these doctors know of or could recommend other than the chemotherapy? Is radiation something that can be done, or any other treatment of that, or any type of maybe immunotherapy treatment?
Joe, thank you. Stage 4.
Yeah, first I want to convey to the question the gentleman just asked my support. And it's a difficult question you're asking. We're not here really to address your direct medical problems, but I can speak in general. In the terms of therapeutics, chemotherapy and radiation therapy remain the mainstay of the treatment. Yet, when we start knowing a lot more about the molecular characteristics of the tumor, we can sometimes, and in actually quite good numbers of times, propose some other therapies that we call targeted therapies, where we're trying to attack the driver of those tumors. That's another aspect. I told you about chemotherapy, radiation therapy, targeted therapy. And now for about 10-15% of patients now, they may enroll into something called immunotherapy, even at the very advanced stage, if they meet some specific criteria. And 2 drugs actually have been recently approved and are standard of care in second-line therapy. So this is if for example, your tumor were not to respond to the therapy, the chemotherapy you're on right now, you should discuss this with your oncologist as to what your options are. And there are many more options opening. And remember that many oncologists' clinics offer research studies and clinical trials that are worth considering.
Do you get a lot of calls almost of kind of I know we're kind of running out of time right now, but as far as last minute efforts, just anything that, almost desperation from folks as far as a different treatment?
Sure. I mean, anybody with cancer and advanced cancer, we're desperate. And so, that's one of the things that we as providers really hope to do, is to be able to provide all the options. And that's why we always encourage patients to seek opinions and to seek different opinions. Because especially in places that have comprehensive cancer centers, where we can get together our tumor boards and our groups and meet as a group and really provide the patients with large groups of people who can provide the expertise in a good way.
All right, thank you. We'll have more after the break.